Today's topic is focused on the endocrine system and aging. When I put this presentation together, I was somewhat inspired by, as I usually am, by works of art. And so you'll see that this talk is salt and peppered with references to different artists, ranging from the Renaissance masters to, who knows, Picasso and modern art. So, hopefully you'll get some appreciation of, in addition to the aging and endocrine system, you'll get some art lessons here. Not that I'm an artist or art historian, but I just enjoy that. And so for those who have not met me, I'm Dr. Jurovich. I'm at the University of North Dakota, where I oversee the geriatrics program, as well as the federal grant from HRSA called the Geriatric Workforce Enhancement Program. And this lecture or presentation, plus many others that we've done, can all be found on the Dakota Geriatric website. So if you just Google Dakota Geriatrics, you can go back and look at just of oodles and oodles of presentations that we've done over the past couple of years. Okay, if we can have the next slide. Okay, so the goal today is just basically two. One is to report how hormone levels change with age, and we're not going to cover every hormone known to mankind. That would be way beyond the scope of this. But we do want to understand what some of the basic disorders are and how they present differently in the older adult. You can see a startled older man here who's a painting from, I think this one's Rembrandt, or no, it's Rubin, David Rubin. So anyways, next slide, please. So we have a case report, 76-year-old female. She has type 2 diabetes who now complains of weakness and lack of motivation. Her spouse reports that the patient sits around the house most of the day, has lost touch with her social activities, especially at the church. In terms of her review of systems, she sleeps more than usual. She takes frequent naps, and she reports being constipated. Her depression screening scale is negative for depression. She does not drink alcohol. Her medications are a multiple vitamin, lisinopril and for hypertension, and metformin for diabetes. The vital signs are normal. On physical exam, she has psychomotor slowing. She has a 3 out of 5 mini cog score, which is screen negative, so she's not manifesting memory loss, although 3 out of 5 is still somewhat of a concern. It's borderline. She has reduced reflexes, a loss of vibratory sense in her feet, and she cannot keep one foot in front of the other for more than 10 seconds, which is a positive Sharpen-Romberg test that indicates the potential for future fall. And her gait speed also is 0.8 meters per second. So I wanted to just ask what people's thoughts are about this. You can certainly put in the chat box if you think that there's an endocrine disorder going on, since that's what we're focused on, or something else. What might that be? So I'll just leave a few seconds here for people to put into the chat box. They think they know the diagnosis here. We're waiting for some brave souls to make the diagnosis here. So Gunjan, why don't we go to the next slide? So I'll make it a little bit easier for you. Here we have some choices. Do you think that her slowness and sleepiness is from hypercalcemia, an elevated high calcium level? Or is it from hypothyroidism, an underactive thyroid? Or could it be C, a overactive thyroid? Or alternatively, could it be too much cortisol in her system? Or could this be an indicator of early and rapidly progressive Alzheimer's disease, which can also cause lethargy? So I want you to think of your answer here, and let's go to the next slide. If you chose overactive thyroid, that would have been the right answer. So this is a little bit of tricky, and you're going, whoa, wait a minute. An underactive thyroid is supposed to cause all the slowness, but what do you mean hyperthyroidism? Why is an overactive thyroid causing this? So that's what we're going to learn today, as to why older adults sometimes have atypical presentations of somewhat common problems. I used to have a faculty member that used to use the reference that it was a tricky wicket, for that, what's that game that you play with, you hit the ball, croquet, the tricky wicket. So that's what this is. We're going into territory that shows that they're not everything that you see in the older adult population is all that you think it is. Next slide, please. Okay, so I wanted to just give you some background information, and I didn't include this fish, the salmon, in here because I like fishing, and I'll admit that it's not a walleye, but the hormonal theory of aging really relates to spawning salmon, where there's this concept that when salmon go to spawn, they produce massive levels of cortisol. And it's all during the spawning season, and then they eventually die, from this massive dose of cortisol. And so there's been a lot of theories that have been brought up as to whether human aging is somehow related to this constant secretion of a hormone that leads to deterioration and death. And I'll say that, well, cortisol levels can go up with age. They definitely are not the death hormone that we would think of. I mean, usually cortisol comes after stress, and so it would be true that if you're under a lot of stress over time, you're going to shorten your lifespan. So I think that's pretty well known. In fact, they did a study, many years ago, where they took mice and they put them on a platform, and water was surrounded by the platform. And they shocked them, so the mice had to jump into the water. And the only other thing that they hate worse than a shock, electric shock, is water. And so, they kept stressing them, and they found that their cortisol levels went up very, very high. And as a result of that, their brain started to atrophy, and they showed premature aging. So when we talk about taking those 2 minutes worth of deep breathing exercises and relaxing each day, there's a reason for that. Next slide, please. So generally, we know that hormones help maintain homeostasis, or that balance between keeping things all things equal and even tempered, if you will. And so as an example, what I just mentioned was the stress activation. So deer in the headlights, right? You get the adrenal system cranking, and you have to make a choice of either fighting or fleeing. And so that's all what the adrenal system is in part doing. Another example would be, people that go into excessive dieting. So this whole caloric restriction actually prolongs life, but it's at a cost. And one of those is that it alters the thyroid system, so that it looks like you're hypothyroid. You've got low thyroid, and it's in part a response to your metabolism slowing down. The body is telling itself, you're not getting as many calories as you should be, or whatever. So your thyroid is going to kick down a couple of notches to conserve your metabolism, so you don't burn up whatever calories you're getting normally. So that's a good example of homeostasis. Changes in thyroid levels, or changes in cortisol levels according to stress, or whether it's caloric stress, for example. Okay, next slide. Yeah, and this is somewhat of it's a made-up graph, but it shows the concepts here, that as you look at the upper part here, there's health going to death. And then on the downward axis there, you can see failure going to normal adjustments of the homeostatic system. And so again, homeostasis being that balance, you can see that with that pink line, that it goes down, down, down with increasing age. So the bottom of the graph is, increasing age. And you can see that there's a point where this dotted line occurs where there's a point of no return. And so in geriatric healthcare and in general, we want to keep people away from this dotted line as much as possible. We want them to maintain their homeostasis, maintain their function. And now we're calling it resiliency, you know, their ability to bounce back. And so why is it that older adults get more long COVID? Well, because they were exposed to more long COVID and its sequelae. And that's one of the, what I want to say, examples of loss of resiliency. They don't bounce back from a viral infection as they had or could have when they were younger. Okay, so we can go to the next slide. This is a little fuzzy, sorry for that, but you know, one of the nuances of copy and pasting from the internet here. But you can see this very colorful graph of showing how certain hormones decline with age. So those include the sex hormones of estrogen, progesterone, and testosterone. Quite honestly, this does not accurately represent the testosterone decline in men, and we'll show you that later. But interestingly, there's a couple of hormones that increase, and one of them is insulin, and the other one is cortisol. And you go like, well, wait a minute, why is there so much diabetes in late life if insulin is going up? And the answer is that the insulin has to go up because it's not seeing the receptors, it's not binding as well. And as a consequence, the body, through its homeostatic mechanism, says, we need more insulin, so let's make more insulin. And hopefully, you know, it tries to create that balance. So this is what we see in the over the lifespan, these shifts in hormonal levels. Now, these are all part of the blood system, right? So if you got a blood sample and they measure it at a certain time in your life, you know, like, I don't know, men can get testosterone levels measured. Well, women can too, but they'll say, oh, you have low testosterone. Well, that's only true in the blood. It may not necessarily mean that you have low testosterone in your muscles. And we'll talk a little bit about that because there are differences between, you know, what we call serum or blood levels of hormones and tissue related levels. And that was the big controversy back in, you know, a couple of decades ago when people, as part of this anti-aging phenomenon, were pushing growth hormone injections. And it did a whole heck of a lot of damage, and it didn't really increase anybody's lifespan. It helped increase a few muscles over time, but it caused more problems than it did good. But it was based upon the observation that growth hormone levels were decreasing with age, and somebody had the bright idea, well, if we, you know, replace that growth hormone and make the blood levels go back up, we're going to make people normal again. And it doesn't work that way. Okay, next slide. All right, so an important point as part of this homeostasis is that with age, one hormone level may be compensated by another. So I gave an example here of where testosterone will decline with aging, but then the pituitary will increase the luteinizing hormone, and so you get these counterbalancing effects. And I just want to take a nod here to this close-up view of a mural from the Detroit Art Institute. I grew up in Detroit, and I have vivid memories of this mural that was done by Diego Rivera. And it was one of the first times that they had multiculturalism and diversity that was expressed as part of the Detroit scene. And so this has always stuck with me, as all these workers, you know, working towards a common effort here, which is, you know, obviously to build the automobile. Next slide. So just as a general rule of thumb, disorders of the endocrine system as we get older can be very subtle. A lot of times from the clinician's point of view, they're very nonspecific. And as that case report that I provided you show that they can be very atypically presented. And so that case report that we talked about, the medical term for it is apathetic, I put in hypothyroid, oh dear, it's apathetic hyperthyroidism. Sorry for the spelling error. So it's hyper, not hypo. So apathetic hyperthyroidism, where it's just the opposite of what you think it is. Next slide, please. So part of the non-specific symptoms include there's a change in functional status, so they may not be able to transfer as well. They may have functional problems in their instrumental activities of daily living, so they may not be able to do the finances that they once did. And of course, all those changes in functional status can represent cognitive changes, right? That might be Alzheimer's disease. And in fact, a lot of the endocrine disorders can cause cognitive impairment or cognitive dulling. They can lead to psychomotor slowing. And again, that's the confusion between what might be driven by an endocrine disorder versus intrinsic or what we call neurodegenerative disorders. And I guess I've got another reference to an artist here. You all remember Anthony Hopkins, Sir Anthony Hopkins from Silence of the Lambs, and the actor. He's acted many more. He's a very avid painter, and he does these wonderful multicolored, paintings of portraits, portraits of whatever. And somebody asked him if what he thought about people who didn't like his art. He says, "Well, that's their problem, not mine." So he's got a pretty good sense of humor there with his artwork. Next slide, please. So I want to turn towards just specific examples. So the thyroid is a good example of fairly frequent changes that occur with aging. And basically, the thyroid has a cascade where the brain, through the hypothalamus and the pituitary gland, produce hormones that are what are called trophic hormones. They're hormones that are produced to stimulate the thyroid gland, which then produces T4, which is the 4-iodinated thyroid hormone, which then gets converted by an enzyme into T3. And so both T4 and T3 are typically thyroid hormones that circulate around the body that help stimulate different things, for body function. And if you have too much or too little of that, you either have hyper or hypothyroidism. And so sometimes you have to replace it, or if you have a thyroid gland that's overactive, you have to knock it out and reduce, the thyroid hormone production. And so it goes. So that's why we test for these hormones, and particularly from a clinical point of view. Just so you know, we use the TSH tests, the thyroid stimulating hormone test, as our primary measurement for either an underactive or an overactive thyroid. So a underactive thyroid would have very low TSH levels, and a underactive thyroid would have high levels of TSH. All right, next slide, please. Well, you can just simply ask whether the thyroid changes with age, and over life spans, it increases and decreases in size. And I would say basically, once we pass middle age, the thyroid gland doesn't really change a whole heck of a lot. So if it's enlarged, it's going to be an issue clinically. And I don't know how many doctors feel thyroid glands these days. It's more quick to just get an ultrasound, but that is an issue. And I think sometimes when I do my annual wellness exam with patients, and they say, I ask them to go around and I say, please swallow, and I'm like, what are you doing to me? It's like, I think I'm strangling them or something, but it's actually, I'm trying to feel the thyroid gland. And about 1 out of 10 older adults should have a palpable nodule. I'm not sure if my track record is quite that good, but if there's any doubt, I do refer people to a ultrasound. However, buyer or clinician, be aware, because it's not recommended that you do routine ultrasounds, because you're almost guaranteed in the older adult population, as we'll see shortly, that there will be nodules there. And then the question is, what do you do with the nodule? Okay, next slide, please. Okay, so I just wanted to point out that even though this graph looks like the thyroid hormones are declining with age, that in essence, from middle age through the age 90 to 100, that you can see that the serum T3, which is in the brown, and then the purple levels here are the serum T4, that both thyroid hormones are essentially within normal limits, right? So even though it looks like it's going down, the fact of the matter is that those the range for normal hormone levels are pretty consistent throughout the lifespan. Next slide, please. And this becomes like an important issue because a lot of times people say, "Oh, I need some thyroid to, I'm just dragging tail and I need some thyroid." So here we can see that T4 secretion will decline with age, but also what happens is that on balance, its clearance is reduced. And so again, that homeostasis, you get the net effect of it remaining stable throughout the lifespan. And this is one of Picasso's famous paintings, very multicolored. And he was always famous for really distorting women's bodies. They always made very big, large arms and legs. And you can read into whatever that meant from his perspective, but that's one of his critiques of his artwork. Next slide, please. So I'd mentioned that TSH is the main test to determine whether the thyroid is under or overactive. And this is just a little bit of a cartoon here that shows what happens with hypothyroidism, so low thyroid activity. The hair becomes coarse. And these are really quite extreme, long-standing conditions that go undiagnosed. So typically, clinically, we discover thyroid disorders much earlier on than in days past. Honest to gosh, I think in my clinical experience, it was only during medical school that I saw really profound hypothyroidism. It's being caught much earlier now. And so part of this is you see the puffy face, and then edema. You might see rings under the eyes. And I always tell my students that if you see rings under the eyes, you also have to think about a condition called gammopathies or hyperviscosity syndrome. Okay, next slide, please. So it would be a true statement to say that underactive thyroids or hypothyroidism increases with increasing age. So this is a 23-year-old study or so. And it shows that how thyroid conditions increase with increasing decade. And there is a gender difference. The green bars here show that women for each age group typically have more thyroid disease than men. Okay, next slide. So basically, with the thyroid conditions, you get things just slow down. And one of the things that I want to call your attention to here in the middle is the issue of constipation, because just about everybody complains about constipation. And so, at what point do you decide that you need to work that up from an endocrine level? And I'd say from a geriatrics point of view, we are pretty liberal with testing for thyroid. So we measure TSH on a regular basis, whether somebody had a fall, whether they complain of constipation, if they have memory problems. Certainly we check for TSH levels if they have a memory problem. So that's part of it. Sometimes you'll see sick sinus syndrome or slowing of the heart rate. And so that could be another indication of thyroid hormone. A lot of people will complain, particularly in their younger years, of cold intolerance. I'm feeling cold all the time. And so that could be an issue. And then, of course, some skin problems, brittle nails, a little pock marking of the nails. These could all be representative of an underactive thyroid. One of the things that's not listed here and is a medical board question is anemia that's associated with underactive thyroid. And so typically you get large red blood cells. It looks like you have a B12 or thiamine deficiency when in fact it's related to thyroid problems. Okay, next slide. Okay, so most typically hypothyroidism is caused by Hashimoto's disease, which is an autoimmune where antibodies are made against the thyroid. The other comment is that if you do find hypothyroidism and there's memory loss, the replacement with thyroid hormone usually does not reverse the dementia on general, but we still look for it. The loss of resiliency with age can lead to these mild cases of hypothyroidism escalating into severe hypothyroidism when somebody gets like COVID or influenza. So that's a key point. And it gets real tricky, by the way, in the hospital setting to diagnose hypothyroidism, because you get a condition called sick euthyroid, and it's like, you know, you really almost have to call an endocrinologist in to help decipher whether it's true hypothyroidism or reactionary hypothyroidism. Okay, next slide, please. So there's this condition both with hypo and hyperthyroidism, what's called subclinical thyroid disease. And so a lot of people don't know quite what to do with it. In this case, the thyroid stimulating hormone, remember the TSH that we use to measure, typically if it's over 4.5, we say, aha, they've got hypothyroidism. But in reality, the T4 gets measured and it's normal. And you go like, well, wait a minute, we did the screening test, it's elevated, but then the thyroid, circulating thyroid hormone is normal. Well, that's subclinical hypothyroidism, and we don't always know what to do with it. But the fact of the matter is that you really probably should not treat it. And in fact, some people live into 100 and beyond may have elevated thyroid stimulating hormone levels. So, you know, it could have some benefit. The other point is that there's an age-dependent difference about thyroid replacement therapy. So people over 70 usually do not benefit from it, whereas people who are 50 to 60 years old may have some cardiovascular benefit from thyroid supplementation. So there's that sort of age-dependent cutoff, you know, related to this phenomenon called subclinical hypothyroidism. Get on the next slide, please. All right, so with elevated TSH, you can't get all excited about it right from the get-go, because half the people who had a blood test with a thyroid stimulating hormone of greater than 5 will actually go back to normal. So you need to make the diagnosis 2 consecutive samples a couple of months apart. And I just make a reference here to this, what we call scintillation art by Chuck Close, who I think just passed away fairly recently, who did all these like little triangles, and you know, you can't really see his paintings until you stand far away. If you look up close, it's just a bunch of dots, and then you go back at a further distance, and so that's what he was famous for. Next slide. All right, so we're going to move into hyperthyroidism, and you know, just a whole variety of symptoms associated with that. Again, instead of intolerance to cold, you now are intolerant to heat, which it all makes sense. You know, the thyroid's ramped up. The famous commercials that we're seeing now with the bulging eyes, or not so much anymore because they have medicines that treat the bulging eye phenomenon. You know, thyroid, you see a lot of people with a thickened neck due to enlarged thyroid. So blood pressure elevation should always prompt concerns about an overactive thyroid. You get muscle weakness, people with loose bowels as opposed to constipation. So a lot of just the opposite symptoms that you see with the underactive thyroid. Next slide, please. So again, I got the spelling right this time, thank goodness. So we have apathetic hyperthyroidism. So that's where just what I just mentioned to you about all these typical symptoms of overactive thyroid are just the opposite in the older adult with this phenomenon called apathetic hyperthyroidism. And so this picture here of this older person really demonstrates a lot of those components of the skin changes, the sunken eyes, the temporal wasting, and just that kind of listlessness. You know, they just aren't getting around and moving around. Next slide. Well, we have a lively painting by David Hockney here, British painter. I don't know, quite honestly, if this has anything to do with hyperthyroidism, but I thought it looked pretty cool, so I included it in this slide here. Most of the cases of overactive thyroid occur under the age of 65, but conversely, 25% or 1 out of 4 occur over the age of 65. And so in the older adult, that 25% do not have the classic symptoms as regularly. They may represent or be presented with new onset of atrial fibrillation, heart palpitations. I can't tell you how many of those little devices, Cardia, and I'm not endorsing Cardia, but people put their 2 fingers on the little strip and they can see whether they've got AFib or not. And then we've got what we call the apathetic variant, which includes depression, withdrawal, and lethargy. So those are sort of the key factors that we look for. And then, if somebody has a broken bone or a collapsed spine, you should always think of 2 things. One is hyperthyroidism, and the second one is multiple myeloma. So anybody that has a spinal fracture, spontaneous or even trauma-induced, it should be investigated for those 2 problems. Okay, next slide, please. So this is a painting by Van Doris that shows that wide-eyed stare. And so the reasons that people get overactive thyroids are what we call toxic adenoma, which is a large growth on the thyroid, little small nodules called multinodular goiter, and then again an inflammatory thyroiditis or Graves' disease. Next slide, please. Well, here we are with the subclinical hyperthyroidism. So we had subclinical hypo. What about hyper? So this is a little bit more ominous. This is represented again by the low TSH, but normal T4 and T3. It's for some reason is linked to atrial fibrillation, bone thinning, and all-cause mortality. So the treatment there is you radioactive iodine. And you use either a beta blocker, such as metoprolol, and or what's called thiourea. Next slide. So multinodular thyroid disease increases with age, and I have a little painting here of a lot of river rocks to represent those multinodular thyroids. But the problem is that the vast majority of older people, particularly women, have multiple thyroid nodules, and so it's never really clear what the significance of that is. And so a lot of times you end up chasing your tail with a lot of these thyroid nodules. So amiodarone, or if you have a CT scan with iodine contrast dye, that may precipitate the hyperthyroidism due to these nodules. And I guess the good news is that less than 5% of the nodules ever turn into a cancer. Next slide, please. Okay, so I want to shift gears a little bit here. As you can see with the tango, we're going to talk about a little bit about the sex hormones. And this graph here on the left is a little better representation of the difference between menopause and what we might call andropause. And I'll tell you, it's pretty controversial as to whether there's such a thing as andropause in men. But you can see that the time point with which the sex hormones start to decline according to age. So obviously it occurs earlier in women. And I would just say that whatever the mechanism is that earlier life loss of sex hormones in women seems to have a protective effect because they live longer than men by 3 to 5 years. So all the pains that you endure through menopause reaps benefits later in life, I suppose. So focusing on testosterone, for men, the testosterone mainly comes from the testicular production, whereas with women, the testosterone can come from the adrenal glands as well as from the ovaries. So you can see sort of the cascade here that the stimulation of the different pituitary gland hormones that lead to the stimulation of testosterone. Men also produce, obviously, estrogen, and conversely, women produce testosterone as well as estrogen and progesterone. Okay, next slide, please. So this just reemphasizes that the 50% of the testosterone in women comes from the adrenal gland, and the other 50% comes from the ovary. And there's this precursor called dihydroxyepiandrosterone, which is called DHE. And there was a lot of research from, decades ago that suggested that DHE levels go down and that it would particularly benefit women if you took DHE supplements. And that turned out not to be true. DHE makes very little difference. However, it can be used in women to treat age-related vaginal atrophy. So we'll see that here shortly. Next slide, please. Yeah, so the DHE, this is what set up the research. The DHE levels, and your eyes aren't going bad. This is just a bad reproduction here. But you can see that the DHE levels are declining with age in both men and women. Next slide, please. So I don't know if anybody knows Frida Kahlo. So she was married to that fellow for a while, Diego Rivera, right? So they were a couple from Mexico. She did a lot of self-portraits, and she was always a tortured soul. But she has an endocrine disorder, a little too much testosterone in her system from probably polycystic ovary disease. And so I'm always fascinated by how she represents herself with, sometimes she represents herself with, facial hair and sometimes not. But anyways, I think that the important points here is that DHEA supplement is not beneficial in any respect for age-related problems. And I made reference earlier about the vaginal use of DHEA can help reduce atrophic changes that accompany with age in the vaginal area. Usually you use Premarin, for a treatment of vaginal atrophy, but this is actually new to me that you could also use DHEA. So just want to make that point. Next slide, please. Yeah, in terms of menopause, it is obviously age-related. It occurs in midlife, median age of 51. And there's always been this controversy of whether when your menses started as a young woman, whether if it started earlier, whether menopause would be earlier. And I think the consensus has been that there's no correlation. So whenever you started your menses has no bearing on when your menopause occurs. So I think really the important part is that a third of women's life is basically spent in the postmenopausal state. And we'll look at what the consequences of that or the issues that are related to that. Okay, next slide, please. So the so-called climacteric can be associated with mood changes, a lot of sleep disorders, and the ever nasty hot flashes. Kind of the bad news is that they usually occur on average between an 8 to 10 year duration for those who do have the hot flashes. And they are more associated as a percentage in African Americans and obesity and those that smoke. So I guess 2 of those 3 factors might be mitigating opportunities to reduce, the side effects of menopause. But I want to bring your attention to this graph because you can see that menopause can occur very late in life in people well over 60. And so it's a smaller percentage, less than 5%, but it's just to be noted that there is a range. And then you also might notice that this is a bell-shaped curve. And so the distribution is that, the vast majority of people experience menopause in their early 50s, but it can occur earlier and it can occur later. Next slide, please. Hormone replacement therapy. And boy, I don't know how this got covered up with the slide. But anyways, there were the pictures covering some of my points here. But bottom line is that hormonal therapy was at one point malpractice if you didn't prescribe hormonal therapy. And then all of a sudden it went just the opposite. It was malpractice if you prescribed hormonal therapy. And so the Women's Health Initiative helped define some of the side effects of hormonal therapy. And you can see all these bad things that can occur in terms of thrombotic events, stroke, heart attack, and breast cancer. And part of the problem is that there's this imbalance between estrogen and progesterone when you have hormonal therapy. And estrogen alone is a little less dangerous than progesterone. But again, there's some problems. And if you apply it topically, as we talked about, with twice a week intravaginal estrogen, there's really very little risk of systemic absorption. So that's good. Okay, next slide. The decision to use hormonal therapy really has to be individualized. We don't use it for primary prevention of anything anymore. So like somebody says, well, I need to be on estrogen for osteoporosis prevention. Yeah, that's not always the case. So we don't use it for primary prevention. You can use it for vasomotor symptoms. So if you do have hot flashes, estrogen supplementation with or without progesterone does reduce those vasomotor symptoms. And if you do choose to go that route, you should use the lowest dose possible, because you still have risks of systemic side effects of estrogens, which include blood clots. And even though the low dose estrogens, they say you can't get blood clots, don't believe it. It still occurs. And maybe not as much as with high dose estrogen, but it's still a real event. And again, to avoid in groups with high risk of adverse events. And so remember, the smokers and high BMI or obese people have high likelihood of thromboembolic events. And so even though those are the people that are most affected by menopause and hot flashes, those are the ones you really should not treat with hormonal therapy if you can avoid it. Next slide, please. Oh, so this Ed Paschke was a very lively painter. Everything was very psychedelic, and he was an artist back when I was at Northwestern University Medical School. He's now passed on, but he's got these just incredible portrait paintings that are very psychedelic without using, day glow paint. These are all just natural paint colors. So I just wanted to point out that there are some alternatives to hormonal therapy. And so you can use paroxetine is a antidepressant that can be used in low dose. Some people use gabapentin. I'm not real enthused about that because gabapentin has a lot of side effects, and it's really amongst those opioid class of medicines that you don't want to get hooked on. Clonidine also has some issues because it's centrally acting and can cause a lot of psychosocial, emotional disruptions that, as well as cognitive problems. At the bottom there, you can see phytoestrogens, methyl-dopa, yams. I love yams. And then lifestyle modifications are all things that have been tried. Sohash has been tried, and there's another one, clover and sohash. Those don't work for postmenopausal symptoms, but the yams maybe. And I don't know if there's a difference between eating yams naturally or taking a yam extract makes any difference. I just don't know. Next slide, please. So a word to the wise here is to try to avoid any replacement therapy, especially over the counter, testosterone, and just progesterone alone, or these so-called compounded bioidentical hormones. They're not good. You don't know what's in the product. There was a study that showed that supplementals have 80% of them have something that you don't even know what it is, and something like 90% of them don't have what they're supposed to have in them anyways. And so the vast majority of a lot of these supplementals just don't stand up to the standards. Next slide, please. I thought I'd make just some reference here about the genitourinary syndrome of menopause. So you can see on the left side here these bullet points of problems with just the anatomy, and as a consequence, there's up to 40% of women can be affected by symptoms of burning. There might be a low-grade discharge, sometimes some bleeding and irritation, dyspareunia, which is painful sex or painful intercourse, and then also urinary tract infections. So the next slide. So typically what we treat, particularly for the dyspareunia or painful intercourse, is to treat with Premarin. I haven't looked at whether the what's the word I'm looking for? The DEA suppositories can also work too. I don't know the literature on that, but basically the mainstay is Premarin. The good news is you only have to use it twice weekly, and there's no risk for breast cancer, because a lot of times people say, oh, if you use that, I'm going to get breast cancer. There's some other agents out there. So there's an estrogen receptor. I have not prescribed this. It's called aspemophene. And then there's another compound called prasterone. And again, I've not used those. There may be some gynecologists that are using laser therapy. I have no idea how that works, but I just have for the sense of completeness to include that as a possibility for treatment. Okay, we can have the next slide. So part of the changes with age include changes in the vaginal pH, the microbiome changes. So there's always an increased possibility of yeast infection, particularly in diabetes and obesity. And so importantly, from a clinician's point of view, infections such as trichomonas and Gardnerella are very rare in older women. And I included this graph here about sexually transmitted diseases because it turns out that HIV is transmitted most commonly in the older adult population. And part of that is the phenomenon of what I call Sun City or Leisure City. A lot of single older adults get into a communal living, and it's party central, and they forget that they need to use protective measures when they have relationships. And ignoring that can lead to exposure to sexually transmitted diseases. So that's just a kind of a word to the wise with our folks who are moving into congregate housing. Next slide, please. And there's this whole issue about the male menopause. We call it the andropause. And you can see loss of muscle mass. They may develop gynecomastia, testicular atrophy, and so forth, even bone loss. So actually, men with bone loss, who have a spontaneous fracture, just like you have to look for thyroid conditions, you have to look for hypogonadism. Next slide, please. So it would be true statement that testosterone levels decrease. And so that red line is what is most important, because that's the free testosterone. That's the stuff that acts on the muscles and all the other tissue. And so, you'd say, aha, look at, the testosterone levels are going down. Let's replace it. And I think I got a slide here that shows that not so fast, because it really doesn't work. So next slide, please. Just to add that that the low T phenomenon that you see advertised on TV can be amplified by chronic opioid or pain pill use. It can be amplified by chronic steroid use, as well as chronic conditions such as heart failure, COPD, chronic renal failure, as well as cancer. In fact, cancer is one of the largest drivers of low testosterone in men. Next slide, please. So the big question, do you get T-gel, testosterone gel, or not to T-gel, is kind of my Shakespearean question here. And there were two major trials, and the T trial and the team trial. And bottom line is that not much happens. You get some early benefits in the first 3 months of testosterone therapy. People feel like they're having better sex, they're having better muscle strength, just feeling overall more potent and better. And that all goes away after 3 months. So that's the bottom line. Next slide, please. So I just wanted to point out, and I say this to my older men patients, is that if you pump iron, you're going to start elevating local levels of testosterone. So it turns out that when you do research and you say, oh, okay, if you're doing resistance training or strength training, the serum testosterone levels don't increase. Well, that's true, but the local levels of the testosterone increase. So whatever testosterone is in the muscle is being produced more in the tissue that really counts. Next slide, please. Yep, and so this is just the whole point of, and it's kind of a busy slide, but it shows that exercise in late life can really benefit, and so it helps reverse a lot of these endocrine disorders that occur. And some people said, well, how about if you take these so-called anabolic steroids and the DHEAs and the testosterone, and they do add some, when I say early benefit again for increasing muscle. They may potentiate muscle strength and building, but then again their effect fades away. And remember the homeostasis. If you're going to give a little bit of extra something else is going to start to decrease, and so that balance gets disrupted when you start adding supplements. I will point out though that anytime people do strength training, and in general older adults need more protein in their system. They don't need more hormones, they need more protein as part of their nutrition plan. So it's 1.6 grams per kilogram of weight for extra protein. Next slide, please. All right, so again, this just emphasizes the importance of strength training, that it can increase over time. And just again, you can see the differences between men and women. So the W70 on the lower bottom there, that's 70-year-old women can show that they can increase their strength. The bad news is, particularly for women, if you stop strength training, all that work that you did for 6 to 8 weeks goes down the drain if you stop within 2 weeks. So you got to keep at it. That's an important, and men too, but they retain their muscle mass for just a little bit longer period of time.